right this very second, there's a highly volatile, remarkably complex biological engine operating flawlessly inside your head.
Oh, absolutely. It's constantly running.
Right. And you probably haven't thought about it once today, but it is just running in the background, dictating your comfort, your ability to speak, and how you process the very food you eat.
It dictates pretty much everything about your oral environment. Yeah.
Exactly. And we have a massive stack of incredibly detailed clinical study notes in front of us today. They are this wild mix of typed diagnostic criteria, handwritten medical shorthand, and these really intricate surgical diagrams.
Yeah, it's quite the collection of data. Very dense.
It is. And our mission today is to decode this dense clinical data into a clear map of human anatomy. We're looking at how the body manages this hidden plumbing system, the sheer chaos that ensues when the mechanics break down, and the surgical extremes required to fix it. We're going deep on the human salivary glands.
It's a fascinating area to explore.
Okay, let's unpack this. Because paging through these notes, the level of intricate engineering happening just beneath the skin of our faces is staggering.
The structural design is truly a marvel, and frankly, a very precarious one. When you look at these clinical sources, you are really looking at the foundational blueprints of human health.
Right, it really feels like looking at architectural schematics.
Exactly. And the goal today is to take these microscopic details, the cellular mechanics, and connect them to the functional reality of your daily life. Because when this specific anatomical system fails, it doesn't just cause minor discomfort.
No, not at all.
Right, it presents some of the most intricate mechanical and oncological challenges in modern medicine.
Well, to understand the diseases, the stones, and the tumors outlined in these pages, we have to establish the baseline. Like, how does this plumbing system actually operate on a normal, healthy day?
We have to know what normal looks like before we look at the problems.
Exactly. And the notes state that the human body produces about 1,000 to 1,500 milliliters of saliva every single day, which is honestly kind of mind-blowing.
It's a huge amount of fluid.
It is. Like, if you picture a large 1-liter Nalgene water bottle,
Yeah.
you're easily filling that up, and then some, with spit every 24 hours.
Yeah, it is a massive volume of fluid to constantly generate and transport, and the sources detail very clearly that this production is not coming from a single centralized reservoir.
Right, there isn't just one big saliva tank in your head.
No, not at all. The body uses a highly compartmentalized system with a strict division of labor. We have 3 major pairs of glands, the parotid, the submandibular, and the sublingual glands,
Okay.
and they are tasked with entirely different physiological jobs.
The breakdown of those jobs between unstimulated and stimulated flow really caught my attention.
Oh, it's a crucial distinction.
Yeah, because based on how the notes describe the fluid dynamics, I'm visualizing the parotid gland like a high-pressure fire hose. Like when you eat, when the system is stimulated by chewing or tasting, the parotid just kicks into overdrive.
It does. It produces a very watery, serous fluid.
Right, but the submandibular gland operates completely differently. It acts more like a slow, constant syrup dispenser.
That's a great way to picture it.
Because the clinical notes indicate it handles 71% of our daily unstimulated saliva flow, producing a thick, highly viscous mucus.
What's fascinating here is that the contrast in viscosity is the linchpin of the entire system.
How so?
Well, from a physiological standpoint, you need that slow, constant viscous mucin coating your oral cavity all day long. It provides continuous lubrication.
So it stops your mouth from just drying out completely while you're just sitting there.
Exactly. It prevents the delicate mucosal tissues from tearing when you speak, and it acts as a barrier against bacterial overgrowth.
Wow.
But when you eat, you need volume. You need that watery, enzyme-rich serous fluid from the parotid to rapidly break down starches and literally wash the food down your esophagus.
So the type of fluid a gland produces is entirely dictated by its daily function.
Precisely. But critically, that same physical property, the thickness of the fluid, is exactly what sets the stage for distinct structural failures.
Which brings us to what happens when that thick, sticky syrup dispenser gets clogged.
Right, mechanical failures.
Yeah. The notes dive into a condition called silolithiasis, which is the clinical term for salivary stones. And according to the data, these stones overwhelmingly affect the submandibular gland.
They do, by a very wide margin.
And honestly, reading the anatomical explanation for this, I find myself deeply questioning our evolutionary design.
It does seem a bit flawed at first glance.
Wait, so the body has a primary plumbing system designed to push thick, viscous, calcium-heavy fluid upward, fighting directly against gravity, through a duct that the notes describe as long, wide, and tortuous. That seems like a biological recipe for absolute disaster. Why is the system built to fight gravity?
It presents a fascinating mechanical contradiction, doesn't it? From an engineering perspective, you are trying to pump a mineral-rich slurry uphill through a winding pipe.
It makes no sense.
Well, the notes explicitly highlight that the saliva in the submandibular gland has a much higher concentration of calcium and phosphorus ions compared to the rest of the mouth.
Right.
But the anatomical layout, with the gland sitting low under the jawline and the duct traveling up into the mouth, is largely a compromise of spatial packing.
Spatial packing, like just running out of room.
Exactly. The body has to fit these essential bulky glands into the crowded architecture of the head and neck. There just isn't much real estate available.
Oh, I see.
So the cost of that spatial compromise is the risk of stagnation.
So the fluid just stops moving.
Precisely. When the flow of that highly viscous saliva slows down, perhaps due to dehydration or maybe a minor anatomical kink, the physical dynamics change.
What happens to all that calcium?
The calcium and phosphorus ions can no longer stay suspended in the fluid, they precipitate out.
They just drop out of the liquid.
Yes. They settle out, crystallize around a tiny piece of debris or a stray cell, and begin to build a calcified stone layer by layer, right there in the duct.
And when a stone forms in a duct that is actively trying to pump fluid, the pressure buildup has to be agonizing.
It's incredibly painful for the patient.
The notes mention Wharton's duct.
Yeah.
If you, meaning the listener, if you lift your tongue right now, you might see 2 tiny bumps right at the base of your mouth.
Behind the lower front teeth, yeah.
Right, those are the openings to Wharton's duct, the main exit pipes for those submandibular glands. And if a stone gets lodged near that exit, the notes describe a treatment called milking the stone out.
Which is exactly what it sounds like.
Yeah, which involves manually expressing it if it's within 2 centimeters of the opening. It is a very visceral image.
It is very hands-on.
Other treatments range from local heat and hydration to sialagogues, which are agents like sour candies that force the gland to rapidly produce saliva.
Basically trying to flush the system.
Yeah, essentially trying to pressure wash the stone out from behind.
It is fundamental plumbing maintenance at that point. If the blockage is near the exit, you attempt to push it through.
If that doesn't work.
If that fails, surgeons might place a temporary stent to physically prop the duct open. But looking at the clinical trajectory, a single stone is rarely the ultimate threat.
What's the bigger threat then?
The danger is the chronic mechanical cascade that follows. The notes detail the progression into chronic sialadenitis.
Which means inflammation of the gland, right?
Relapsing, remitting inflammation.
Yeah.
Yes. Because the saliva is chronically blocked, it pools inside the gland tissue.
Oh man.
And stagnant fluid in the human body is a breeding ground for bacteria. You get repeated, deep-seated infections.
So the gland is just constantly under attack.
Every time the gland swells and fights off an infection, it sustains damage. Over time, the healthy, functional saliva-producing cells are destroyed.
Just wiped out.
They're wiped out and replaced by dense, non-functional fibrous scar tissue. the gland atrophies, it shrinks and hardens.
Wow.
So simply due to the physical mechanics of gravity and fluid viscosity, the organ slowly destroys itself.
So we have mechanical blockages, the plumbing gets backed up and calcifies, but then the source material shifts focus to structural anomalies that are, honestly, far more ominous.
We move from plumbing issues to cellular issues.
Yeah. What happens when a patient comes in with a noticeable lump in their cheek or under their jaw and it is not a calcium stone? How does a clinician figure out what they're actually dealing with?
That's the critical diagnostic pivot.
And this is where the notes offer a really stark reminder of the human element. There's a clinical examination script written out in Urdu in the notes.
Yes, the script for the clinicians.
Translated, it reads, Assalamu alaikum. I am Dr. Hanif. I will examine your nose, ear, and neck. Please cooperate. It grounds all this dense medical data.
It really does. It puts a face to the pathology.
Exactly. There's a patient sitting on an exam table, likely terrified about a mass growing in their face.
That human context is vital because when a clinician begins that examination, they are essentially conducting a high-stakes investigation.
What are they looking for right away?
The notes outline a specific matrix of clinical red flags, literally boxed in red ink in the sources that point toward malignancy.
Okay, what are the red flags?
They are looking for persistent pain, rapid and unchecked growth, and skin involvement.
Skin involvement meaning what exactly?
Where the skin over the mass becomes tethered or discolored, and they're looking for fixity.
Fixity.
Fixity means the lump does not move freely beneath the skin. It feels anchored like it's fused to the surrounding bone or muscle tissue.
Got it. Well, the red flag that jumped out at me was nerve palsy. The notes mentioned facial nerve palsy and paresthesia,
Yes, the neurological symptom.
which is a tingling or numbness, right? And the notes specifically associated with a tumor called adenoid cystic carcinoma.
A very aggressive type of cancer.
Right. If a lump in your cheek is actively paralyzing the muscles in your face, that immediately tells you it's not a clogged duct. It's something aggressively invading the local wiring.
It's actively destroying the nerves.
But to confirm exactly what kind of cells they are dealing with, the notes detail a diagnostic tool called FNAC, fine needle aspiration cytology.
A very common biopsy technique.
And they grade the results using the Milan system. The statistics here are incredibly tense, like non-diagnostic still carries a 25% risk of malignancy.
Even when they can't get a clear read, the risk is high.
Yeah. Atypia of undetermined significance, or AUS, carries a 10 to 35% risk. Suspicious jumps to 60%, and malignant is 90%.
Those are daunting numbers for a patient to hear.
Here's where it gets really interesting for me. If you do a needle aspiration and the pathologist grades it as suspicious with a 60% risk of cancer, why not immediately rush the patient into the operating room?
It seems like the logical step.
Right. Why not just surgically remove the entire gland and the surrounding tissue just to be unequivocally safe?
The hesitation comes down to understanding what cytology actually is and the profound concept of risk stratification in surgery.
Okay, break that down for us.
With fine needle aspiration cytology, the pathologist is not looking at a solid, intact chunk of tissue. They are using a microscopic needle to vacuum out a loose soup of individual cells.
Just floating cells.
Right. When a result comes back as atypia of undetermined significance, it means those isolated cells look biologically agitated.
Agitated how?
The nucleus might be slightly enlarged or the cellular border is irregular. They are behaving strangely, but they haven't mutated enough to definitively meet the strict criteria for cancer. It is a biological gray area.
So you don't have the full picture of how those cells are behaving in the actual tissue structure.
Exactly right. And because of that uncertainty, you have to weigh the statistical risk of the disease against the guaranteed trauma of the cure.
The trauma of the surgery itself.
Yes. You cannot perform radical, life-altering surgery preemptively because taking out a major salivary gland is not a benign procedure.
It's a massive deal.
Furthermore, the clinical data stresses that a vast majority of salivary gland tumors are entirely benign. The notes heavily feature pleomorphic adenomas.
I saw those. They look intense.
They are benign, slow-growing tumors that originate from uncommitted reserve cells, and they can grow to massive proportions.
Yeah, the text describes them forming a distinctive dumbbell shape as they grow and physically squeeze their way through the stylomandibular ligament tunnel,
Which is a very tight, bony bottleneck at the base of the skull.
expanding outward into the peripharyngeal space. They warp the anatomy, but they do not invade and destroy surrounding tissue the way a malignancy does.
Right, they push things out of the way rather than eating through them.
The notes also highlight another specific benign mass, Warthin's tumor.
Ah, yes, Warthin's.
The data shows a strong demographic association here, noting it almost exclusively arises in older males with a history of smoking.
There's a very clear correlation there.
Yeah, it develops from ductal epithelium that has been chronically irritated by tobacco smoke over decades. So knowing the cellular identity of the lump, whether it's a Warthin's tumor, a pleomorphic adenoma, or an aggressive carcinoma, completely dictates the surgical game plan.
It dictates the margins, the urgency, and the approach. You do not want to subject a patient to radical surgical dissection, risking permanent facial paralysis to remove a benign Warthin's tumor.
Right, because that could have been managed with a highly conservative localized excision.
Exactly. The surgeon has to map the battlefield before they ever pick up a scalpel.
Well, let's look at that battlefield, because the reality of those surgical risks transitions us directly into the operating room.
It's a daunting environment.
When a surgeon actually has to cut into the parotid gland to remove a mass, reading these notes, it sounds less like standard surgery and more like trying to pull a chewed piece of bubble gum out of a tangled web of fine silk thread without snapping a single strand.
That is a very accurate analogy. The mechanical difficulty of a peritectomy cannot be overstated.
What makes it so difficult?
The central complication, the overarching physiological minefield in this procedure, is the facial nerve.
The wiring for the face.
This nerve is responsible for every facial expression you make. It allows you to blink, to smile, to raise your eyebrows, and anatomically, it doesn't just run adjacent to the parotid gland.
Oh, it goes right through it, right?
Yes, the main trunk of the nerve exits the skull and plunges directly through the center of the gland, splitting into tiny microscopic branches that weave through the glandular tissue.
Which means the tumor is often sitting directly on top of, or literally wrapped around, the very wires that control the patient's face.
Exactly.
How does a surgeon possibly navigate that without severing the nerve?
Very, very careful.
I mean, the notes describe a strict protocol of utilizing anatomical landmarks before any tumor removal begins. They mention the tragal pointer, which is a distinct V-shaped piece of cartilage right near the ear canal.
Yes, that's one landmark.
But the text explicitly highlights the tympanomastoid suture as the most reliable landmark. Why is that one the gold standard?
Because soft tissue like fat, muscle, and tumors can shift, swell, or distort during surgery. A surgeon needs an unmoving anchor point.
A fixed reference on the map.
Right, the tympanomastoid suture is the literal physical seam in the skull where the bone surrounding your ear canal fuses with the hard mastoid bone behind your ear. It never moves.
Oh.
By locating that exact bony seam, the surgeon knows the main trunk of the facial nerve is consistently located just millimeters away.
So they find the trunk first.
They find that main trunk, and then they meticulously trace every single microscopic branch outward, physically peeling the tumor away away from the nerve fibers. To even get access to that area, the incisions they use are fascinating. Like, the notes detail a modified Blair incision, but they also list a facelift incision.
Yes, the surgical approach is evolving.
I was genuinely caught off guard by that. Why are oncological surgeons utilizing cosmetic plastic surgery techniques to remove potentially malignant tumors?
It represents a critical evolution in how we define surgical success. Decades ago, the only goal was oncological safety.
Just get the tumor out.
Remove the tumor at all costs. But modern head and neck surgery recognizes that the patient has to live with the physical aftermath. A traditional incision leaves a highly visible, stigmatizing scar down the center of the neck.
Which is a daily reminder of the trauma.
Exactly. A facelift incision requires immense technical skill because it forces the surgeon to operate through a highly restrictive window.
Right, they don't have as much room to work.
But it allows them to hide the surgical scar inside the natural curves of the ear and up into the hairline. It balances the ruthless necessity of tumor removal with the preservation of the patient's cosmetic dignity and quality of life. It's an incredible merging of disciplines. But even with flawless surgical technique and hidden scars, biology can react in wildly unpredictable ways.
It certainly can.
The notes list early complications like hematomas and temporary nerve weakness, but the late complications, this is where the anatomy gets deeply strange.
You're talking about Frey's syndrome.
Yes. The notes outline this condition called Frey's syndrome. It states that months or even years after a completely successful surgery, a patient might sit down to eat a meal and the skin on their cheek will suddenly begin to intensely sweat.
It's bizarre to witness.
How does the body leap from chewing food to localized facial sweat?
Frey's syndrome is a profound demonstration of the nervous system aggressively trying to heal itself, but failing to recognize the new anatomical reality.
Okay, how does that work?
To understand this, we have to look at the microscopic wiring. When the surgeon removes a section of the parotid gland, they're forced to cut through thousands of invisible, microscopic parasympathetic nerve fibers.
The signals from the brain.
Yes. In a healthy body, those specific fibers carry the signal from the brain that says, we are eating, stimulate the gland to produce saliva.
But the gland is gone.
The target organ has been removed, but peripheral nerves have an incredible drive to regenerate.
They don't just give up.
No. After the surgery, those severed parasympathetic nerve endings begin to grow outward, desperately searching for a target to connect to.
Just looking for anything to plug into.
Because the overlying skin of the cheek has been laid back down over the surgical bed, those nerves mistakenly grow up into the underside of the skin flap. There, they encounter the sympathetic sweat glands of the skin, and they wire themselves in.
So the brain is sending a salivary command, but the hardware has been completely rewired.
It is a physiological short circuit. The brain registers the taste of food and sends an electrical impulse down the parasympathetic line.
Thinking it's talking to a salivary gland.
The signal means to say produce saliva, but it hits the new, mistaken connection, fires into the skin, and triggers the sweat glands instead. The body's regenerative drive is so powerful that it overrides its own functional logic.
That is wild. This deep dive has completely dismantled how I view something as mundane as saliva.
It's much more complex than people realize.
We started by looking at the sheer volume of daily fluid dynamics. The delicate balance between the high-pressure serous fluid and the heavy protective mucin. We mapped out how simple mechanics like gravity and viscosity can conspire to form dense calcium stones that literally back up the plumbing and slowly destroy the gland from the inside out.
We also explored the immense diagnostic pressure of investigating structural abnormalities.
Oh, absolutely.
Deciphering the cellular warnings within the Milan system, and navigating the incredibly fraught biological gray areas between benign atypical cells and aggressive carcinomas.
And finally, we tracked the absolute surgical tightrope required to fix it. Watching surgeons use fixed bony seams in the skull to map out the facial nerve, utilizing cosmetic techniques to preserve the patient's dignity, and bracing for the bizarre regenerative short circuits like Frey's syndrome in the aftermath.
It's a true medical gauntlet.
It is a hyper-complex grid of fluid dynamics and electrical wiring, and it is quietly, seamlessly operating in your head right this second while you listen to this. Thank you so much for bringing these incredible clinical notes to us today and giving us the chance to unpack them. Keep questioning the hidden systems you take for granted, keep looking closer, and keep diving deep.
Before we go, there's one final, deeply profound detail buried in the histogenesis section of these notes. It involves an ongoing scientific debate regarding exactly how these complex tumors form in the first place. The notes highlight the bicellular stem theory.
What does that theory suggest?
This theory posits that diverse tumors, like the massive pleomorphic adenomas, originate from a very specific population of uncommitted reserve stem cells located deep within the intercalated ducts. Now, consider the primary biological purpose of an uncommitted reserve cell. Its entire existence is dedicated to healing.
So they're the repair team.
Yes. If you burn the roof of your mouth on hot coffee, or if you sustain a minor tissue injury, these reserve cells leap into action. They rapidly divide and differentiate to rebuild the damaged tissue and restore health.
Which is amazing.
It is. But the staggering implication of the bicellular theory is that these exact same heroic repair cells are the ones that occasionally mutate and lose their stop signal.
They forget how to stop healing.
Exactly. Instead of repairing a tiny injury and resting, they just keep building, endlessly multiplying until they construct a massive tumor. The exact biological mechanism designed to heal your daily injuries might be the exact same mechanism that, with a microscopic shift in genetic instructions, builds your destruction. It is a razor-thin line between cellular healing and cellular chaos.